Hello, everyone. Welcome. We are so excited to have you all here today. My name is Patrika Elise. I'll be your MC for today's AI4 webinar. We are so excited to have everyone here. I just have one quick housekeeping item before we jump in. So please make sure to use the Q&A box for your questions as opposed to the chat. This makes it easier for us to organize your questions and get to as many as possible. So please make sure to use that Q&A box for your questions. Now, today's topic is AI's impact on clinical decision-making. I'd love to go ahead and welcome our panelists to the virtual stage.
Hello, everyone. Hello, Brian. Hello, Rebecca. Hello, all you attendees. We're so excited to have you here. Thank you for taking the time out of your busy day to talk to us, to listen to the webinar. Without any further ado, we'll do self-introductions. My name is Daniel Lackland. I'm the content lead for AI4. I'll just be moderating the session here. And without any further ado, Rebecca, would you like to just give a little introduction to the webinar attendees?
Sure. Thanks, Daniel. So as Daniel said, I'm Rebecca Mishuris. I'm a practicing primary care physician and the Chief Medical Information Officer at Boston Medical Center Health System, which is a safety net academic organization in the heart of Boston, serving the underserved majority. So 80% of our patients are either on Medicare or Medicaid. Half of them live at or below the federal poverty limit, and about 30% don't speak English as their primary language. It's a fairly unique population that we take care of.
Thank you so much, Rebecca. Brian, would you like to offer a self-introduction to everyone?
Yeah, absolutely. My name is Brian Dianza. I'm the medical director for digital health for University Hospitals Health System in Cleveland, Ohio. We're a large academic quaternary health system that services a good quarter of the northeast portion of the state. We do have a medical school attached to us, as well as a children's hospital and right around 20 or so outlying hospitals. In addition to being the medical director of digital health here, as you can see, I'm also a head and neck surgeon. So just coming from the OR today, so excuse the scrub attire. So I balance my time between clinical and then also leading some of our executive decisions, administrative decisions, and operational decisions on the digital health side. And then I do have some background, background in sort of founding and starting a augmented artificial intelligence company for asynchronous telehealth, as well as being a consultant to a number of digital health startups in the area. And generally just, having some insight and utilizing AI technologies and pushing them out here at university hospitals and being a consultant in that respect as well.
Thank you so much, Brian. We're so happy to have you here as well. Scrubs or no scrubs, doesn't matter. Patrika, if you wouldn't mind, let's just go ahead and jump into question number one. Okay, and Rebecca, I'd love to kick this one over to you to begin, if you don't mind. The question is, how much adoption of AI have you seen for clinical decision support? And exactly how widespread is this technology right now?
So I think we're kind of on the verge of a boom that we're about to see. I would say historically, AI has been used in very niche clinical areas, right? The most notable probably being among radiology to date, but we're starting to see it in other areas, kind of at the point of care, not just in radiology, but in other areas of medicine as well, like pathology. And then when you get down to medicine in the hospital, right, we start to see AI in identification of deterioration of patients, right, sepsis identification or other deterioration measures. We're starting to see it in spaces like readmissions and how do we address and reduce readmissions. I don't think it is yet, and Brian may have a different perspective on this given his role, but it's not as pervasive as I think people might think based on what they read in the news. And that has a lot to do with not the technology itself, but the implementation. Healthcare is kind of notoriously lagging in its adoption of technology. And part of that is because we want to make sure we get it right? We are holding people's lives in the balance. And part of it is just because we like to do things the way we've always done them. And new technology doesn't necessarily lend itself to that. But But I do think that we're about to see an explosion of the use of advanced analytics in care delivery.
Thank you so much, Rebecca. Brian, what are your thoughts on the same topic?
Yeah, no, I think Rebecca has it right on. For us, we've used it within our radiology department, our imaging department for quite a while, and we had some physicians actually from university hospitals back in the sort of late 90s, early 2000s that had developed some AI when it's associated with different MRIs and functional MRIs. So we've used it there for a bit. When I think about as far as adoption, I like to think of it within sort of our health system, our sort of big health systems, like Rebecca has, and that I work for at university hospitals. And then I also think of it, outside of these health systems, within, private practice, within, individual providers. And I would say on the latter aspect, it really is non-existent these days. You have small providers or small provider groups that, frankly, don't have the means or the technology background or the IT to support something like this. But for most larger academic health systems, it's used in some form or fashion. Recently, I have seen it being used more in some patient intake. So that sort of digital front door that you talk about with folks often is where patients are being sort of integrated into the system with an AI sort of chatbot, if you will. Sometimes those are less AI and more just sort of automated responses. But there are some systems that use it in various areas, as an intake process. I think it is starting to become more pervasive within even smaller health systems. They're starting to tinker with AI when it comes to clinical decision making and sort of those high value areas. And we've got a number of different pilots here at university hospitals that perhaps I can talk about, in forthcoming questions. But I would say right now we're in the pilot phase in a lot of different areas, and trying to understand the value of AI, I think is the key right now, is trying to gather the data to say, how helpful is this? And I think a lot of health systems are starting to sort of figure out where it works and maybe where it doesn't. So, I think right along with Rebecca, it seems to be poised for expansion in certain areas as we get that data in. But certainly right now, limited to pilots and largely it's larger academic health systems that can afford to do it. Your individual doctor down the street, your private practice provider, unless they're really progressive and they've got a pretty good support team around, it's hard for it to sort of be that pervasive these days. But that's where I guess I see it right now.
Excellent. Yeah, thank you so much, Brian. Sorry, Rebecca, were you about to say something? I didn't mean to.
Oh, no, I was just going to add, I think that the patient-facing aspects of AI could be really important also, right? We saw this kind of explosion of health-related apps that are all patient-facing, right? A lot of that is actually done completely outside of the healthcare system, for good or for bad. And so I think that's another place where we will start to see it. Brian mentioned the kind of digital front door chatbots, but even in scheduling, right? You can use AI to determine which appointment a patient would be best suited for. So I think there's opportunities, not just kind of provider or clinician facing, but also patient facing.
Excellent. Thank you both for your thoughtful answers. Patricia, let's jump to the next question. Okay, so you listed a bunch of challenges and some use cases as well. I'd love to dive a little further into the use cases here. Brian, if you wouldn't mind, I'd love for you to kick this one off. The question is, where are you currently seeing AI delivering value in clinical decision support? Please offer as many detailed examples as possible.
Yeah, so right now, when we get outside of the sort of standard areas of pathology, radiology, I think we do see some value there clearly in being able to extend our providers' ability to see more and do more. One of the areas we've seen, and I think just in general, is we think about these sort of high impact areas. So what I mean by that is, places where the emergency department, like the ICU, where sort of the cost of missed morbidity and the cost of inefficient care is high. We've seen some benefits there in being able to really use predictive modeling and the machine learning and AI to sort of tell us kind of where things might be going wrong. So, for example, and I guess I'll use this example to kind of highlight what I think are kind of two prerequisites that we see in determining value of AI. One would be that I think the AI has, or the disease process it's going to deal with really has to have a sort of clearly defined problem that causes significant morbidity. So it has to be something that has the potential for providing high value because it's a serious problem. And I think the second is that that there has to be enough sort of evidence-based scientific literature or consensus around it for the appropriate medical treatment to provide kind of a baseline for the AI to build off of. The AI, the idea is that it learns, but you have to have a certain knowledge base for it to start with. And so those two things of having sort of a serious problem that has serious morbidity and costs associated with it, and also having something that has enough knowledge base to be able to provide learning off of, because that's the whole idea of AI, is it's sort of this self-learning mechanism, but you have to have that sort of initial bolus of information to feed it. So the example would be something like urosepsis, is sort of this getting septic from, a UTI or a urinary tract infection. That is something that, has a lot of high quality literature that has shown that early intervention with medications, primarily antibiotics, can really significantly reduce that morbidity and progress into like septic shock and ICU admission and all that. And so that's that sort of first sort of caveat, that first prerequisite. And then the sort of second is that there's a good amount of evidence to show that the sooner that you can get things into the patient, for example, antibiotics, the better. And so one of the AIs that we use here at university hospitals that we've been sort of working with, training it to identify those sort of clinical features within the chart, that it's able to sort of comb the chart, so to speak, and determine, they're seeing vital signs go up, they're seeing spikes in labs, white blood cell counts going up, and as well as provider notes, and sort of give that initial insight into say, hey, this patient actually is looking like they're moving more towards sepsis, and alert the care team to say, now is an appropriate time to give an antibiotic. Because historically, in the example of urosepsis or sepsis in general, health systems and providers in the hospitals, that was an area there was needed optimization of getting those medications in sooner, so the patient does not progress to septic shock, does not progress to the ICU, and all the costs associated. So, that's, I think, for me, those key areas, ICU, ED, those high value, high impact areas where you can make a big difference in improving the patient's outcomes and the patient's hospital course, while also being more efficient with the care, reducing costs. And so those are the areas where we see as, the delivering value for us, where those are the programs that we're trying to expand.
Excellent. Thank you so much, Brian. Rebecca, what are your thoughts?
So some couple of general thoughts, I think, to start with, and then I'll go into an example. But I think generally, right, Brian's right on. We're looking to use this technology in places that will have high impact, essentially delivering on the quadruple aim, right, of improving quality of care, reducing cost of care, and improving both the patient and clinician experience in receiving or giving that care. Sometimes that's hard to tease out, right, because this technology is not implemented in a vacuum. And so sometimes it's hard to know whether the technology is having the impact on the, whatever your outcome measures are, or just the increased, or increased attention to the issue, or even just getting people to understand what the evidence-based medicine is, right? Brian was saying that we have to start with some sort of evidence base before the machine can learn anything. And, part of AI is actually just getting us to practice evidence-based medicine. And there's a lot of art to medicine, which I think most people don't realize how much art there is in what we do still, even though there's a ton of science in it, right? There is still some art to practicing medicine. And that's also why Brian and I are never going to not be doctors, right? There will always be a need for physicians, because we talk a lot about augmented intelligence rather than artificial intelligence, right? We're we're putting a computer in to help, not to replace. And then I think part of the other portion, right, is making sure that we have the data and being able to extract that data in some meaningful way for the machine to learn. And that's where sometimes we fall down in medicine, right? Because although we document a lot, we don't necessarily document in a way that a computer can learn it. Thankfully, I think we're at this point in the US, right, we're kind of all off of paper now. And so that's a little bit easier, but still, a blood pressure could be documented in a dozen different places, a dozen different ways. And so how can you make sure the machine is picking up all of those things? In addition to kind of clinical deterioration that Brian was talking about, I think one of the other areas we're seeing AI used that can have kind of really big impacts on both patient morbidity and mortality, as well as kind of cost of care, is in readmissions and identifying patients who are at risk for readmission, and then identifying why they're at risk and intervening on that risk. Again, it means that we have to have the data that goes into identifying why someone is at risk for readmission, because the readmission is often not, solely resting on the clinical picture, right? It's the home situation they're going back to. It's whether they pick up their medications at discharge. It's whether they understood what they were supposed to do with their medications at discharge. There's a lot of different pieces that go into that. And where I work in the safety net, social determinants of health are a huge part of readmission risk. And so being able to identify those risks and then identify patients who are at risk for readmission because of some other input, but identifying what that input is so that we can then intervene on it, right? It's not enough to say this patient is at risk for readmission. You have to explain to me why they're at risk so that I can put supports in place to try and prevent that readmission. And so, the complexity of healthcare, I think, is really borne out when we start to try and use AI to augment that healthcare. And it's partly because we use so many pieces of data, so many pieces of information as inputs in order to determine what happens with the patient.
And just to follow up on that, I think what you're saying, it really speaks to this idea of the importance of the patient-facing AI and the ability to not just gather information, but also engage the patient, which in many cases is that sort of secondary or even sometimes primary benefit with these patients, is just getting them engaged, informing them of when they need to come back, what medicines they need to take, and being able to do that, I think, is really, really important. I think another area that I was thinking of as you were talking about was in the emergency department. So, having patients effectively triaged before they get to the emergency department, or even after they get to the emergency department, to the appropriate level of care. And so ED, emergency department avoidance, is a big thing for us. We've been looking through a number of folks in the AI realm and vendors to help us with that because of the way things are these days, especially exacerbated with COVID, whether it's folks avoiding the ED or avoiding the hospital entirely and then coming in even more sick, or people avoiding the doctor's office more commonly, and then they come to the emergency department more sick. And so the ability for AI to provide not just the data and the support to the clinicians, but also that patient engagement piece is something that I think, sometimes overlooked, but it's really an important part of it, what kind of outcomes you get, what kind of improvements you get in health, because a lot of the time, we can have the best providers in the world, we can have the best facilities, the best protocols, but if people don't show up until they're real sick, it's hard to provide them efficient, effective care.
Excellent. Thank you both so much for your answers. Really nice to hear those. Patrika, why don't we jump to the next question? And I'm also excited to talk about challenges because we have some Q&A coming in from the audience too, which will be really timely. Okay, so the first question is, what problems or challenges exist with AI technology today? I'm sure there's lots we can talk about. Rebecca, you're smiling. You want to kick us off here?
I'm smiling mostly because in a lot of cases, the technology is the easy part. It's the implementation that's the hard part, except in AI, where I think the technology is also still evolving.
Excellent.
No,
just
no
to
pun
remind
intended.
you, excellent. Just to remind you, we actually did break that question into two. We have technology and then implementation, in case there's any. Okay, cool.
Yes. No, I remember that. But that's why I was smiling. So from a technology perspective, and I do think, no pun intended, right? AI is still evolving. And that is, kind of part and parcel of that technology. One of the biggest challenges that we have in the population that I serve is that we serve an underserved population, which necessarily means that a lot of these models are not trained on the patients that I serve. And so how do we know that my patient is going to react the same way to whatever intervention that the model is telling us that we should take? And so it's actually incredibly important, the same way that it's incredibly important to make sure that the population is well represented as a whole, right, in randomized controlled trials, kind of the gold standard of evidence-based medicine. It's also incredibly important that their data is involved in training these AI models, because otherwise we have no idea how things are going to react, right? If you look at the pandemic, for instance, right, we know that our minority races and ethnicities were much harder hit by the pandemic, not because of their race, right? Because of all the other things that go into kind of historical structural racism and redlining and things like that. And, that is borne out then in the data that we see in terms of who got sick. And if you train an AI model on a population that doesn't look like that in terms of, how does COVID progress, you're going to have no idea how it progresses in a different population. And so I think one of the biggest issues, again, is around the data acquisition and making sure that we are training these models on kind of representative data, and then understanding where they fall down, right? Understanding where the models fall down, where they predict things differently by race or gender, where the kind of pathophysiology has nothing to do with race or gender, right? And understanding how you then have to adjust the model because of that.
Yeah,
Excellent. Thank you so much.
I think it's spot on. I don't have a whole lot to add to that other than, to say that when it comes to, the data and where it's been acquired and how it's been acquired and how it can be biased in different ways, we think of racial disparities, ethnic disparities, gender disparities when it comes to how some of this data has been acquired and resulted in clinical guidelines being developed on this. I think Rebecca's right on that it's certainly, you have to be very careful of how you're training these AI models, that it may not apply to different patient populations. And in fact, I think in some cases, it can actually worsen disparities. You can actually build in this idea of, structural racism, for example, into the AI models. And then it can exacerbate, health disparities. So I think it's a really critical piece of acquiring that data, and then how the AI and those algorithms are building things. A lot of people, thought, well, AI, it's colorblind. It's something that, will take care of things. You don't have to worry about, discrimination. But again, it's built into the data at times. So I think that's a critical part to recognize with one of the, I think, key sort of issues with expanding AI technology.
And then the only thing I'll add to that is that AI is a black box, right? To like many people, right? Most people, maybe everybody on this call other than Brian, AI is a black box, right? And that
me too sometimes.
But that becomes really hard to explain to people how it's working. And so I actually think part of the kind of challenge with AI is getting it to a place where you can explain it in a way that people can consume it and understand it, and not just the providers, right, or the clinicians, but also the patients, to understand, well, how did you make that decision around my healthcare, right? Because we, the vast majority of the time, right, basically if patient's conscious, you should be talking to them about what the next step is, about what the therapy is, or the work, whatever the evaluation is going to be, and having some shared decision-making with the patient. But if you can't explain to them why you're making that decision or recommending one thing over the other, that becomes an incredibly hard conversation to have.
Excellent. Yeah, thank you so much for your perspectives. Patrika, let's jump quickly to the next question. So this question is talking about challenges related to the implementation specifically Brian, do you have any thoughts specifically on implementation you'd like to talk about?
Yeah, I think we've touched on a couple of them already, but the two big problems that I see, one is really around provider acceptance. Getting the providers to say, what's in this black box of AI, and so that's a big problem. I think it's really inherent on not just the patients, or rather the AI vendors, but also the providers, to be a part of the conversation, going in. And so it's not just sort of you like to unveil this is the new AI system, so it's part of that conversation at the front end. But that's a big barrier to that implementation is getting provider acceptance as to what Rebecca said, that kind of black box, so to speak, of AI. I think as providers, we're kind of naturally suspicious of everything. We're sort of, as clinicians, we're sort of taught to sort of be very discerning when it comes to data, when it comes to, really anything that is data driven or changes in our sort of clinical practice, and making sure that we have good reason to sort of change how we practice. So I think that's generally can be a barrier sometimes. A challenge to overcome when it comes to implementation is getting doctors on board, essentially providers on board. But as I mentioned, I think there's some key things that can be done to kind of ameliorate that process and make sure the providers are engaged in the process from the beginning to the end, not just kind of unveiling it to them. The other thing I would say is that the other sort of challenge to implementation, I think, is generally around what we've talked a little bit about before, is this sort of access to high quality data, but in the respect of many health systems are looking for the results of the AI, improvement, and wanting to have clear return on investment. And so I think that data piece can also be a barrier for implementation, because many times these AI technologies, they don't have a whole lot of data behind them that it's proven out. It's new stuff, it's innovative stuff. And so you get that whole chicken and the egg situation where they want to try out the AI technology with your doctors to see if it works, but then the health system wants evidence to show that it works. So there's that sort of interplay there that I think is something that is part of the implementation challenge as well. So, I think those are the two big areas I see, but I think there are a number of others.
Yeah, I completely agree. And I think Brian's got it spot on, right? And part of the doctors, right, like our discernment and our hesitation is that we hold very dear that we are not supposed to do harm to our patients, right? And so how do I know that you're going to put this thing in my computer that I don't understand, and make sure that I'm actually taking better care of my patients, not worse? And so that becomes a real barrier to folks. I think the other piece, right, I tend to joke that 80% of health IT implementations is actually people and process, and only maybe 20%, sometimes less, is the technology. And I think that holds true with AI as well, right? So it's really around people and process. And I think one of the benefits of a lot of health IT implementation is that as you go through it, you get to augment and change the process around the technology. And so that's something to think about. And then, the last thing I'll say is that we have not, we all implemented electronic health records, some of us multiple decades ago, but some more recently than that. No one has kind of realized the ultimate potential of having all of this data, right? But AI, machine learning, big data allows us to start to deliver on that promise of having all of that data and learning from millions and millions and millions of medical records, and understanding science in a way that we can't through randomized controlled trials, right? That maybe have tens of thousands of patients at the most, right? Or through other types of statistical analyses. And so this is one way that we are going to realize the benefit of electronic health records, but it's a little bit scary, right? Because it's new and it's technology and no one quite understands it, except for maybe the people who are building the models. So again, right, it comes down to the ability to explain what you're doing and show that you're having an And part of that showing you're having an impact, again, right? Like these are not implemented in a vacuum. And so how do you tease out where the AI has the impact versus changing the process versus, augmenting who the people are that are involved?
Excellent. Thank you so much, Rebecca.
Daniel, one more thing I'd just like to add, when we talk about that sort of barriers to implementation, gets back to what I'd mentioned before with, initially where we still, large health systems have their own challenges, but then if we think beyond just the big health system, the independent provider, smaller provider groups, it's important to recognize that just about half, I think just under half of providers are still independent. And so scaling AI, if we think of it sort of more of a national lens or a global lens even, is going to be, I think, a challenge in that respect, that we have a lot of independent providers that, they don't have that IT support system. They don't have like 20 people in IT working to make sure the AI is implemented correctly. They many times don't have, they don't have data scientists to make sure that the correct learning is taking place, that we're taking advantage of the data. So, I think that's a piece that I'm sure there's somebody working on solving that issue right now of bringing AI to independent providers. But that, I think, is something, I think, inherent within how healthcare is set up that's a little bit different than some other industries where AI has become more pervasive because of the way healthcare is set up. It's still very siloed in many ways. So I just wanted to mention that.
Yeah, of course. Thank you so much. Yeah, that makes total sense. So Patricia, let's jump to the next question. And for all the attendees listening, thank you so much again for being here. I'm keeping a record of your questions and I'll ask them right at the end. Thank you so much for your patience. So Brian, Rebecca, for anyone here who's, thinking about doing some of this stuff for themselves or already working on AI projects at their respective practices, it's helpful to hear stories of just kind of what's happened specifically in your experience. So the question here is, please tell a story about an AI project that either went really well or that encountered difficulties. What was the tool you used or built? How did you approach the project? And what sort of value was or was not delivered in the end? Rebecca, it'd be great if you would start us off here.
Sure, and this kind of goes back to one of the examples we gave earlier in deterioration, right? And identifying patients who may be clinically deteriorating before they've fully deteriorated, right? So that we can actually intervene. And I will preface this with the fact that we actually didn't end up implementing the AI, right? And so this was about understanding the model and understanding the data and understanding where it was going to deliver benefit to the quality of care we were delivering and the cost of care we were delivering and where it wasn't. And so the very first, so we at our hospital had essentially an kind of very simple algorithmic assessment of patients' vital signs and a couple of other things that identified whether they were at risk for developing sepsis or not. And our EHR vendor came out with the ability to use some AI and machine learning to augment that. And we went through a process of evaluating it to determine whether that was going to actually augment the care that we were delivering. And so that involved kind of setting up a shadow system where we were running both models simultaneously, our kind of very basic model and the more advanced analytics model simultaneously on the patient data to see, is it going to identify the patients appropriately? And do we actually identify patients earlier or more patients or the more, kind of the right patients, if you will? And what we found actually was that because of the way that the AI model was set up, it was alerting on more patients, but that was distracting us from the patients who needed the attention because we were seeing more alerts, right? Rather than kind of the same number of alerts, but on different patients. And so that was a really important learning for us that, maybe we would catch some additional patients in our basket who might be on their way to deterioration, but it was alerting so many patients that we were totally distracted and unable to focus on the patients we needed to focus on. The other thing we realized is that it was alerting on patients who we were already intervening, right? If we've identified and are intervening already before the the algorithm can tell us that we need to, it's not really useful, right? Like we're already at the bedside, we're already dealing with it. We need to know the patients who we're not at the bedside for, right? Who 2 steps or 5 steps down the line might need an ICU bed. And so I would say that that was a number of years ago at this point that we did that evaluation, and these models, right, necessarily continue to evolve. And so we will continue to kind of readdress and reassess the implications of those kinds of models. But that was, I think, a really important step for us to understand how the model was going to perform in our institution. And I think really is getting to one of the things that Brian has been bringing up, right, around the physician offices that don't have the resources to do that kind of evaluation, right? And how important it is that we have large institutions that can do that and then share that knowledge, disseminate that knowledge to others. Because like with EHRs, right, the kind of private doc office on the corner was the last place to implement the electronic health record. And it was because it was expensive, right? The platform itself is expensive, and implementing it is really expensive. And then maintaining it is expensive. And there was actually had to be quite a bit of government support, right? Federal support to facilitate those implementations. And we're going to see the same thing with AI unless there's some sort of centralized approach to implementation. But that centralized approach kind of necessarily has to have that evaluation step embedded in it.
Thank you so much, Rebecca. I mean, that was so illuminating. Brian, would you like to also share an experience similar or different?
Yeah, absolutely. I think, you know, this experience was similar, and I'll share a technology that was actually fits both parts of it. It was, you know, there was success for it, and there was also challenges. And then perhaps another one around patient engagement with our ED folks. But the one that Rebecca was reminding me of was the exact one I talked about earlier, was this idea of this identifying patients who are at higher risk for sepsis. And so our challenge at the beginning was really getting, you know, a good implementation and really good idea of how we were going to track the data. And I think we did a good job of setting up the team to define those key performance indicators, find a good way for that data to be tracked, and then utilize that data as well. And so that's something that I think many health systems struggle with, is, you know, going from data rich to data driven, that there's an extra setup and an extra framework that needs to be set up around that many times. And especially with AI, with the amount of data that's going to consume and then also spit back at you. So that's, I think, a key part of it. Now, where we did struggle with that same technology really gets back to this sort of adoption issues that we talked about, implementation issues with providers. You know, providers were aware of it, but once we started getting into the details of, you know, the decisions that were being made, you know, the providers wanted to know, well, that doesn't, you know, that's different than what way I've been trained. How is this determining that? And so that was where you get to that, you know, like Rebecca was saying, that sort of black box of the technologies. And it is an area of it's a little bit difficult, because you've got vendors that, you know, they've got their intellectual property, so they don't want to hand over, you know, the keys in the house to you. But your providers want to know, like, how is it coming up with these decisions, especially if it's different than the way they've practiced. Especially if it's saying, well, this patient needs antibiotics. The provider's like, well, that doesn't make any sense. I'm looking at all the same data. I don't think they need antibiotics. So that's definitely something that we struggle with the one particular technology, and something that we're still working on, is trying to, how do you get the provider adoption when you don't have, in many cases, the ability to explain to them what's gone into it, and exactly how it works. So, you know, we've been working through it, though, and I think one of the things that's been helping recently is really explaining where the data sources are coming from. That's generally a good thing. That gets back to what I was saying, where it's got to have a baseline to learn off of. And if they're trusted data sources that providers know, they're more likely to sort of take that leap of faith and say, okay, well, you know, if the American Urologic Society data is into this, then I'd be more likely to accept those recommendations. You know, one I guess specific to COVID, one technology that we adopted was getting back to that emergency department avoidance. and triage. And so we've looked at a number of technologies there. And I think we've had some success in building relationships with a couple of vendors around reducing those readmissions and reducing representations to the emergency department through patient engagement tools that utilize AI technologies. I think the key there has been that we've had a very focused efforts towards the reasons why we're adopting these technologies. It really revolves around the idea of value-based care, of improving quality, reducing costs. That's something that our health system and many health systems across the country are starting to look at as a driver of technology adoption and strategic initiatives. And so that was something that we sort of rallied around that technology, and we're able to set up a team that helps support it, not just from procurement and implementation, but also improvement. So that sort of feedback loop of getting the data, bringing it back into the system and saying what kind of changes can we make that's going to help support the end goal of reducing readmissions and representation. So we didn't see it as a single technology that we're using, but part of a larger effort of reducing readmissions, improving the quality of the care we're providing. So I think that's a key piece. Anytime you're using these AI technologies, a lot of times we are incentivized to use it just by it's something flashy and new. But I think the key part is seeing it as part of your larger strategy of how you're improving quality of care and how you're improving that value for the patient. And so many times the technologies that we once were using because they look cool or they sounded cool. I mean, AI, it's sort of like a hip new thing. But when we started seeing it in the frame of, what's our end goal, and then what are the tools we need to be a part of a whole sort of strategic initiative around improving value-based healthcare.
Thank you both so much for your stories. Let's jump into some audience Q&A here. The first question is from Nasser, and they say, one of the challenges deploying or adopting AI into the health system domain is dealing with the FDA and HIPAA in respect to data, and otherwise managing the rules and requirements for AI. And so the question is, have you run into any challenges like this? And if so, how are you approaching them? And either of you, feel free to respond as you see fit.
Rebecca, I'm going to let you start this one because I don't have as much, I think, insight into this as you might have.
Yeah, and I would say I don't have a ton of experience in that space either. I think, we are in a place where the regulations around medical technology and medical devices really needs to catch up with AI. And so, the FDA is just approving kind of the first AI as medical devices as we speak. And so I think it's an area that really needs to kind of, it's lagging behind the technology itself when it comes to healthcare. I think from a HIPAA perspective, right, kind of protecting patients' data, as we all, part of training these models is sending our data to the vendor or whatever platform has the model to train it on our own data, right? And so making sure that you do that in a secure way, in a way that protects your patient's data is incredibly important, with the caveat that you've got to send enough data for the model to know what's going on, right? So I don't have to send the person's name, but I've got to send some sort of unique identifier so that you know that the patient with the admission on this day is also the patient who came into my office a week later. And I've got to send age, and I've got to send race and gender. And so, there's all sorts of things that we would typically consider protected health information, right? Personal health information that we need to send. And so it becomes then a matter of making sure that the security in that transfer is there. And also the security on the other end is there so that the data is not going to leave those four walls either, figurative four walls.
Yeah,
Excellent.
and I
Thank
think,
you so much.
and just to speak a little bit on, the FDA requirements and HIPAA requirements, and I guess I think the larger question that's being asked is, what are kind of the rules and regulations, the basic requirements for an AI technology? Where are we getting that data to say what's what sort of processes are required to be in place, checks and balances with that data or with that AI technology. I think there are some societies, some medical societies that have started to develop requirements around AI and machine learning when it comes to reporting that data and talking about the results of these AI technologies. And so I think that that's something that will increase in quantity as time goes on. I know there are certain societies that are looking at requirements for AI technologies when it's going to be brought into the healthcare sector. So I think it's something that is starting to become, there's starting to become some awareness about that. Yeah, I will say just at university hospitals, you know, FDA clearance for some of these technologies is a barrier we face as well. And so often when we're engaging with folks, with vendors, we need to make sure that they've sort of cleared those hurdles, because it can be a multi-year, you know, 6-7 figure process to get that stuff cleared. So you want to make sure that if you're going to engage with vendors at the front end, that you have an awareness of that timeline, that it's, you know, something they haven't gotten FDA clear, they really haven't gotten some maturity in that area. It's going to be a little bit before they're going to get in the door. So I think that's an important piece. We have a team here at University Hospitals, an innovation team that helps and takes a lot of that legwork from those of us who are on the clinical and operational sides of digital health and AI, where they're able to take some of those sort of prerequisites, if you will, and make sure that those prerequisites are met when it comes to FDA clearance, when it comes to HIPAA compliance, and then how the data is sort of stored and distributed and used. Because one of the challenges with some of these AI systems is that, you know, they're self-learning, and they may aggregate data from multiple hospital systems, multiple health centers. And so you need to make sure that you have, frankly, a team that is going to be that's going to be top of mind. And for us at University Hospitals, it's partly our legal team, it's our UH Ventures innovation team that's going to make sure that those I's are dotted and those T's are crossed.
I spend a lot of time with our information security office and our lawyers to make sure that, right, that we are doing things that protect our patients. We want to be able to take advantage of these technologies, but not at the expense of our patients' privacy and quality of care.
Excellent. Thank you so much for your responses. I know we're talking a lot about the data that was used for these different algorithms. Sabrina asks, again, how are you dealing with data that might have been trained on a certain group that leads to some sort of bias? And actually, Michael specifically asked the question, if you're using a vendor tool, are the vendors proactively informing you about which databases were used to train the algorithm? And if so, what steps you can take to avoid bias? So kind of similar, I'm curious, for the vendor perspective, are they doing anything? And also just your proactive steps. I know, Brian, you just talked about this, and also Rebecca, you did as well.
Yeah, I guess I would say up until a year ago, nobody was talking about this. Like, this is not something that vendors were telling us about when they came to us or even aware of. But it is something that we are now actively asking everybody who comes in when it comes to an AI technology. What's your data source? Where are you getting this from? And ensure that it's something that is not, again, going to exacerbate these health disparities, that is not biased against minority populations, gender-based disparities as well. So it is something that we have, adopted as it is part of that sort of line item and prerequisites questions that are going to be asked to everybody. But I will say this is something that has changed drastically in the last 18 months or so.
Yeah, I completely agree, right? It's kind of become part of a checklist that we have, right? Do you have FDA approval? Where does our data go, right? And how do you, what's the data that this has been trained on? And, similarly to the way that Brian and I read scientific manuscripts, where we're looking to see what population was included in the trial, right? You want to know what population was included in training the model and understand how that population may or may not look like the population you're then trying to apply the model to. and what biases may or may not have been introduced as a result of using that population, right? And so, but it's incredibly important for the vendors to recognize that. And I agree with Brian, right? I think a lot of them are, but not everybody, right? Sometimes I ask these questions and I get some blank stares, which is not a good response for the vendor. But really important for people to recognize the potential to introduce those biases and account for them, right? Like you can't just say, oh yes, we looked and here's the population, but like we looked, here's the population, here's how, this demographic affects the outcomes. And so we've accounted for that as we've built the model further.
Yeah, I think it's really, it comes down to, is asking the question, of where you're getting your data sources, and then having, in many cases, it's not just one person, it's a team of people that are then reviewing, the data source, the responses, coming up with follow-up questions of how, what Rebecca just mentioned. So, from a practical standpoint, you really do need a team that's going to be aligned around all these prerequisites, that sort of data source of which is very important.
And then I think, right, Brian and I don't go and implement these things for tens of thousands or hundreds of thousands of people at once, right? We pilot them. And it's because we want to understand how they're going to perform in improving the quality of care that we're delivering, or reducing cost, or improving the patient experience, whatever our kind of KPIs or outcomes that we're looking for. We want to understand in a pilot setting how that's going, how the model is going to work before we spread it across the entire population that we care for. So you will never, I don't know, never, but today, right, like you're not going to see us just go in and implement across the board. We're going to pilot. And that's part of kind of the checklist, right, is to understand how does it perform in our setting.
Excellent. Thank you so much. We just have one last audience question that we're going to ask, and then it will be all over. This has been amazing. The question comes from Michael, part 2 of his question series. The question is about the future. Do you have any concerns about long-term de-skilling of physicians or others if they end up becoming used to the decision support systems that we're talking about? What do you think?
I think the skills will change, right? Places where AI has been in use for a long time, radiology, pathology, nobody's going to say those folks have been de-skilled, right? Nobody's going to say that they're not as, their clinical acumen isn't as good as it was 20 years ago. But the AI really is there to augment our ability to understand what's going on. There is exponentially more data that we are looking at now than 20 years ago, 40 years ago, 50 years ago. There is exponentially more kind of medical understanding and knowledge that we have to learn. And yet medical school is still only 4 years long, right? And residencies have not grown in length, which I think most of us who have to pay back loans are thankful for. But all of that information has to be accounted for as we care for patients. And so I don't think it's a de-skilling. I think it's a kind of an augmentation of the skills that we have and the way that we work. But absolutely people become dependent on them, right? You look at not even AI, right? Just kind of decision support to say, your patient's due for a mammogram, right? People are then dependent on having that functionality in the system once they get used to it. Because honestly, right, like, do I have to remember that someone's supposed to get a mammogram every 2 years and their last mammogram was 18 months ago? And so they should know that it should come up in 6 months, right? Like, is that the best use of my clinical time and clinical knowledge? Probably not. And so I then am dependent on having that reminder in my system. But I still know all that medical knowledge, right? That hasn't gone anywhere.
Yeah, no, I think that's spot on. I guess my short answer is I'm not concerned in the current state that we have AI and the way it's being used, because as Rebecca and I have talked throughout this hour, is that it's in many cases being used to augment providers and improve efficiencies rather than replace providers or replace caregivers at all. And so I think from that standpoint, in the short term, I don't know that AI is advanced now or will be in the near future to be able to truly replace a physician's skill set entirely. And so I think that's an important piece, because we talk about de-skilling. I mean, certainly 100 years in the future, maybe we'll be concerned about that. And the AI technologies have really expanded, to really replace physicians or replace decisions. But right now, the data, frankly, is not there to be able to fully replace a physician or a provider or a nurse practitioner or a nurse or anybody. I mean, the hands are still needed. The human mind is still needed. We still very much are as much of an art as a science. And so I think that part of it gives me, I guess, some solace to know that my job is safe, and that I'm not going to lose my skills in the next 10, 20 years. But, I think Rebecca had a really insightful comment about changing the skills that providers are taught and that they will use. In medical school, for me over a decade ago now, we were taught really, it's books, it's the science of medicine. You're reading a book, you're going to class, and then you do your clinicals, and then you do your residency, and it's largely you're taught based on what your superiors have learned and the way they do things. But this sort of using AI is a new thing, and so nobody can teach doctors coming out of medical school their physicians unless they tend to take an interest in AI and really go into it and really get into the details of it. They're not going to get that sort of information handed down to them. So I think it, to me, speaks to the need for this sort of education within medicine of being able to teach residents and medical students coming up, how to look through data, how to really be knowledgeable of what does AI even mean, machine learning, and the sort of needs around that, I think, and the prerequisites that we've talked about throughout this hour. Teaching all that, I think, is going to be really important to the future generation, and I think will be really important to ensure that AI continues to become valuable and improving the care and augmenting the abilities of providers to provide high value care.
Well, thank you so much to both of our panelists. That is it. One of our participants, Michael, wrote a paper on descaling. If you're interested, I posted in the chat. Aside from that, we are totally finished. Thank you, everyone. I'll kick it back over to Patrika. And Brian, Rebecca, it's been an absolute pleasure.
Wow, I know I have learned so much, and I know this audience is going wild with virtual applause because that was amazing.
Woo!
Thank you both so much for sharing today, and thank you, Dan, for moderating and keeping us on track. This has been an incredible conversation, and I know we'll want to continue to talk about this for a while because this is amazing. So thank you all. And for the audience, thank you so much for joining us today. Be on the lookout for future AI4 webinars, as well as our upcoming conferences and events. Thanks so much, and we'll see you soon. Have a great day, everyone.
Bye, Brian. Bye, Rebecca.